Steve, give us the 30-second pitch of who you are, what you're trying to do, and what you want to do.
Sure. So my name's Steve Posnack. I guess now we just went through a reorganization. So I'm the executive director of our Office of Technology at the Office of the National Coordinator for Health Information Technology at the U.S. Department of Health and Human Services. And I also walked here. So
Oh, you did?
It's turning into summer in D.C., in case you were wondering.
In that suit, yeah, I feel for you.
So, we were originally formed by executive order under President Bush. So we're a little bit over 14 years old now at this point. And our mission is to improve the health IT ecosystem in the United States. So we work on, a lot of you may be familiar with a phrase called meaningful use. That was what healthcare providers got incentives to adopt electronic health records. Ambulatory, inpatient, we've had, wild success at getting the adoption up now, and so now we're really working on making those products useful, working with industry. My office runs what's called a Health IT certification program, so we go through some regulatory-related work, as well as coordination with a number of different federal agencies, CMS being the kind of primary one, but also working with DoD, VA, many of the other agencies that are now going through EHR acquisitions. They have certification requirements built in that connect to what my office regulates. That's kind of a quick summary.
That was a nice summary. So in your role, what are some of the interoperability challenges you struggle with? Because your focus is really interoperability and standards. And you told me yesterday, or when we spoke yesterday, that, standards and interoperability, we both agreed, may not be the sexiest topic when it comes to technology and everything, but when those work, everything is seamless. So talk a little bit about the challenges there.
Sure. Again, I don't remember the gentleman that was just speaking about, walking into the office and it being 1990. So you can find me on LinkedIn. I didn't bring any business cards, but being able to say, like, you can find me on LinkedIn is a disruptive change to the way that we engage as professionals. And equally, if you see a healthcare provider today, they're like, send me a fax. Here's my fax number, right? And that is still the predominant way in which healthcare providers communicate. So one of the changes that we're trying to make is building into workflow, making it easy to use the computer. And so a lot of what we've seen recently is that the EHR has been successful in adoption. We provided the right incentives, the market environment. But now as healthcare providers go to use their systems, they're clunky. They're not working as well as they need them to, and they're making them less efficient. So that's kind of against the rhetoric that we delivered, in terms of providing, novel ways for healthcare providers to use what's called clinical decision support, drug allergy interactions, all the other things that computers can be really good at and help providers. We're now looking to help improve, working with industry vis-a-vis those means. So, e-prescribing is something that we talked about. If you've gone to the doctor in probably the better part of the last 5 years, it's likely that the next thing that they asked you after they decided that they wanted to prescribe something was, like, what's your pharmacy? What pharmacy do you like to go to? They look it up in the system. You need infrastructure there for a directory. They find your pharmacy, then they just send an electronic prescription. All that works because there's a lot of standards work that, my office has worked on with industry. For every healthcare purpose, we call them use cases and contexts you may be familiar with, there are standards that are associated with them. And so a lot of the work that we're doing now is the standards that are available need to be constrained. They need to have a little bit more refinement to be what's called fit for purpose. So whether it be for transitions of care, a lot of you may be in a position of being a caregiver. You want to have a care plan. So trying to find ways to represent both the structured and unstructured data for that type of information is the next step in helping providers deliver better care.
So how do you create standards for all the HHS components when they are so very different? They have different goals and different customers, if you will. So
part of our role as a national coordinator is we, in some cases, coordinate with many other federal agencies that work on these issues. Some of you may be familiar with the National Library of Medicine. They actually have a substantive role in some of the specific what are called vocabulary standards. So if you want to represent medications, there's a standard that the National Library of Medicine maintains as a steward, which is called RX norm. So they normalize a lot of the medication data. Equally, they are the steward for some of the other clinical representations. But then when it comes to like FDA, as an example, they have a whole international footprint, and then so we kind of intersect with them as it relates to some of the mission activities that we're involved in. When it comes to administrative transactions and getting claims, healthcare claims paid, CMS has a role. So it's a lot of back and forth. You'd be surprised how many agencies have regulatory authority in healthcare over standards and setting the way in which the market needs to. Maybe that goes without saying. It's kind of a rhetorical point. But the work that we do a lot of times is around coordinating, making sure that there's alignment. So most recent example is on e-prescribing again. For Medicare Part D, I'm sure you may be familiar that there's a prescription drug benefit. CMS has authority to accept standards for, or regulate standards for how Medicare beneficiaries have their prescription data transmitted. And we also have that as part of our certification program. So there's a lot of these intersection points with respect to how standards get adopted and which federal agencies, use them in the cadence and the schedule and things of that nature.
So what type of role do emerging technologies play in your office's mission? And are you looking at blockchain? Are you already using it? Are you as advanced as Jose is?
Yeah. So Jose's points are great because there's a lot of different uses. You can cross off blockchain on your bingo card, right? So I thought going at 9:30 I'd be able to tick it off for you. So we are, I'll start on blockchain first. We initially did an ideation challenge. So if you're interested in blockchain in healthcare, we did it what's called under the American Competes Act, we can do challenge competitions. So we did an ideation challenge, and so we solicited white papers. And so we got over 70 white papers submitted to our office. We picked the top 15 about, what are the different use cases or novel approaches for using blockchain in healthcare. And they're all publicly available. We did a co-sponsored a workshop with NIST, who's also looking at standards for the various kind of distributed ledger technologies that are out there. So all that's publicly available on our website, healthit.gov. And the other areas that we work on is around, and this will be one acronym that I'll expose you to that you may not be familiar with. One of the newest standards in the healthcare space is called FHIR, F-H-I-R. And so it's a RESTful API-oriented way to exchange healthcare data. So as opposed to the traditional, kind of fax mentality, a lot of healthcare today is sent using documents or other types of transactional standards. And so FHIR is going to enable a more API mobile approach related to expanding the number of use cases that are available to mobile apps. We'll do a quick show of hands because it's early, right? Who's got an iPhone? Okay, there you go. We know the market penetration. Apple released iOS 11.3. That includes a new health records app. That health records app uses FHIR to connect to hospitals to get your health information. So you might want to check it out if you've, God forbid, visited a hospital recently and you have data there. You may be able to download your health information directly through using your, issued login credentials. So that's an area where we're trying to advance the API technology now in healthcare.
You can't really talk about health IT or health data without mentioning the security aspect.
Sure.
So what kind of work are you doing in that space?
Yeah, we so in terms of where we fit, as was mentioned earlier, there are optives in the Department of Health and Human Services, and then there are what are called staff divisions. My office is a staff division, so we report to the Office of the Secretary. So if you're familiar with the Office for Civil Rights, who does HIPAA enforcement, things like that, they're one of our sister agencies underneath the Office of the Secretary. So we collaborate quite a bit with them related to privacy and security challenges and regulatory enforcement and the like. We also have our own working relationship with the industry. Some of you may be familiar with the NHISAC, the information sharing community for healthcare security. So we collaborate with them as well as the Assistant Secretary for Preparedness and Response at the department, who's primarily responsible with our CIO's office for cybersecurity related responses. So there's a lot of coordination, again, in our middle name that we do from a cybersecurity perspective. We equally, as part of our certification program, have some certification criteria that are related to security, encryption, and the like.
Okay, we're going to take 2-3 questions. 2? Okay, Matt is roaming the floor. All right. Our own quiz.
You're not allowed to ask any questions.
Hey, Steve. Great discussion. Just a quick question. there's been a lot of talk about using APIs all across the government to enable agencies to ingest a lot of data. Are you using FHIR as your primary standard for APIs, or are you using some other standards to try to get everybody on the same page?
So one of the misconceptions for our office, even though we have health IT in our name, is that like we don't do any procurement for our own IT services, right? We're supported by the department as a whole. So whoever from Adobe that keeps calling me to offer me services, I'm just kidding, just kidding. I love Adobe. But like, I'll often get phone calls like, can we talk to you about your data systems or your data storage? And I was like, we don't do that type of procurements. So a lot of work that we do is supporting our other federal agencies that do have missions and programs that relate to getting data from the outside. So you could look at CDC, CMS. They actually put up a new API for provider reporting for some of their quality programs. And that was work done with the U.S. Digital Services. And so we've been talking with them about the potential in the future as FHIR matures further, that you're going to have a whole bunch of electronic health record systems, in their enterprise, data systems that will be available to federal agencies to then connect and really pivot and change and almost flip 180 degrees the way in which we engage with the public sector. So you see a lot of instances today where agencies are many-to-one reporting. And you may see a future where the agencies can reach out with the appropriate, privacy and security related, components to then get that data themselves. And so making it more of a, bidirectional flow as well as on a kind of as needed basis. And we're looking at that as a way to reduce provider burdens. There's a lot of burden involved in collecting all the data that gets reported to, say the collective us. So if we can change that around to just say, do your job, love it, collect data as part of the patient, experience and working with them in clinical care. And then when a federal agency is ready to get that data, and this is, kind of the future, let them, come and collect it at that frequency or whatever, period of time that they need it. And then you don't have to do anything. And so that's a future that, I would say like we'd love to get to, and that's going to be a lot of incremental steps. But that's one of the changes that we're looking forward to.
We got one more question. Oh, over there.
I'm Jean Vettel from Army Research Laboratory. I just have a question. Whenever we think about trying to have data about individuals that can be shared freely across for the experience for the individual, we still have to deal, and I feel like you must deal with this a lot with standards, of companies who essentially want to protect proprietary information or keep their loyal customer base based on the fact that they know the most about them versus something else. So I'm just wondering, what's your thought space for how you essentially motivate someone to want to do what's good but still be successful as a business?
Sure. So one of the things you should be familiar with that's in our space is what's called the 21st Century Cures Act. And so you may be familiar with it if you support FDA or some of the other agencies, NIH, they've been doing precision medicine. There's a whole section, Section 4, that deals with health IT and changes to my office's authority and the focus that we need to work on. And one of those areas is related to what's called, I guess the industry slang now is information blocking. And so Congress has defined what's the behaviors associated with information blocking, and they declared it illegal. They said you can't information block. And then they gave the Office of the Inspector General, as part of HHS enforcement authority, to impose fines up to $1 million per violation of, in this case, the health IT developer kind of information exchange space. So this is ongoing regulatory work. We have a regulation, a proposed rule that my office is working on that's due out later this year. We're targeting September for its release. My office's role is to come up with what are called the exceptions. So if you see this as everything's illegal, and then we have to come up with the kind of use cases and exceptions under which there may be a privacy and security reason why someone may not want to share the data, or they may not trust the security practices of the recipient. Certain types of examples like that we need to work through to figure out where are ways that we can support commercial practices that help data get exchanged when it needs to be, as well as incent or provide the right behavior environment for people to exchange data, not only because it's the right thing to do, but because it's kind of an industry and moral imperative at this point.
Okay, thank you. Well, Steve,
Thanks.
Thank you so much for your insight. We appreciate it. A big round of applause for
Thanks.
Steve Posnack.
Appreciate it.